Everyone. Good evening, everyone. Today we'll be talking about lumbar canal stenosis, and this is in association with GAPIO, along with in collaboration with Association of Spine Surgeons of India. Thank you very much, everyone, for giving us an opportunity to be here. I'm Dr. Aditya Singh Bhati, consultant neurosurgeon, Apollo Hospital, and I request Dr. Sushil Jain for the opening remarks, please.
Thank you very much, Dr. Bhati. So I'm Dr. Sushil Jain. I'm head at Apollo Hospital, Indore, and also happen to be the advisor for GAPIO, appointed recently in last year. So GAPIO is basically Global Association of Physicians of Indian Origin. It is a non-profit organization which was established in 2011 with an aim of bringing about 1.4 million physicians of Indian origin across the world together on one professional platform. And so currently we have around 57 countries with members spreading across various specialties, subspecialties, and super specialties. The GAPIO is basically dedicated towards this vision of improving health worldwide. And we conduct these type of sessions practically almost every week, covering various health topics and areas so that we can spread and share our knowledge with the other members of the organization. That I'll hand it over again back to Dr. Bhati. Carry on the sessions, please. Thank you. Dr. Bhatt, you have to unmute yourself, please.
Yeah. First talk would be by Dr. Karthik Kailash, and he is a spine surgeon at Sri Ramchandra Medical Center, Chennai, with more than 25 years of experience. He has done his MBBS from Madras Medical College, Chennai in 1987, followed by MS Orthopedics from Madras Medical College in 1989. His special interests include minimal invasive spine surgery, spine infections and deformity and correction, and many more. I call upon Dr. Karthik Kailash to please talk about the definition, natural history, and the evaluation and conservative management of lumbar canal stenosis.
Thank you, Dr. Bhati, for the introduction, and thank you, GAPIO, for having us on this very important topic. Just about a few months ago, I turned 60, and then my son said, "Hey, Dad, you're welcome to the Senior Citizens Club." Then I looked at the definition and then said the senior citizen is actually a lot older than the 60, as per WHO. But then the panacea of all this is that as we get older, degenerative disorders of the spine seem to take the cake in terms of the spinal problems. And the lumbar canal stenosis happens to be the foremost of this, wherein majority of the people suffer from the disorder and the care is multifarious with this. So we have two very, very brilliant speakers and very senior speakers, Dr. Venkatesh Krishnan and Dr. Amol Rege, to take us through this important topic of lumbar canal stenosis. And I would like to invite Dr. Venkatesh, my very good friend from CMC Vellore, to talk on definition, natural history, evolution management, conservative management of stenosis. Now, Dr. Venkatesh is very well known in entire India in the Spinal Society. He's been a leading member of the Spinal Society with a lot of publications, credits. He's a professor and head of the Department of Spine Surgery, which is one of the biggest departments in CMC Vellore, and has got numerous publications, notably in tuberculosis spine, and he's an authority in tuberculosis spine and in spinal deformities. Over to you, Dr. Venkatesh, for your lecture.
Thank you, Dr. Karthik Kailash. So, thank you for that wonderful introduction. And I thank the GAPIO for inviting me and to present a few things about lumbar canal stenosis. So today I'll be talking about, these are my disclosures. And today I'll be talking about lumbar canal stenosis, basically its definition, the etiopathogenesis, the natural history, clinical presentations, investigations, and I'll touch upon something about non-operative management. My colleague, Dr. Amol, will be talking about the surgical management after this talk. So, what is the lumbar canal stenosis? Basically, it means that there is a narrowing of the spinal canal, especially the lumbar canal, with compression of its neural elements. As you all know, that the spinal cord ends at the lower border of the L1 vertebra. From the lower border of the L1 vertebra up to the S2 vertebra, you have the dura, which is extending. And inside this dura, you have the various nerve roots, which are going to the legs, which contribute to the lumbar canal, actually. So any stenosis which is happening in this place, especially from the lower border of L1 to the S2, upper border of S2, will contribute to, it will be called as lumbar canal stenosis. So this is an anatomy you can see here, the vertebra in the front and the partially resected posterior elements in the back. And you see this lumbar canal, how it is being divided. So as I told you, dural shield, and a little bit outside the dural shield, which is called the lumbar canal. So you have something called the central canal, you have a lateral recess, you have a foraminal zone, and you have an extraforaminal zone. So each one will be stenosis will be caused by your own particular problems, and some problems can cause stenosis in more than one level, and each one will have its own presentation, and each one will have its own investigation to find out, and management also varies. So every part has a different pathology and a different kind of management. There are some things, even though degeneration is the commonest cause for lumbar canal stenosis, there are many other associated pathologies, okay, which can also cause lumbar canal stenosis. So we'll also touch upon briefly about that so that we'll know what are the differential diagnoses to make apart from other degenerative lumbar canal stenosis, which is the most commonest variety. So how it is classified? So it is basically classified based on the etiology, the location, and the severity, the lumbar canal stenosis. So if you see it based on the etiology, so these are the various etiologies which can cause lumbar canal stenosis, and degenerative canal stenosis being the topmost, almost 80%. Very rarely you can have less than 2 to 3%. You can have congenital or developmental lumbar canal stenosis, which are seen in very young people. Usually these canals are totally different. As you see, these canals will be very narrow, they'll be in a trefoil shape, and they can be associated with other pathologies also. The next commonest type is the spondylotic, that is degenerative spondylolisthesis, which is causing lumbar canal stenosis. Even though degeneration without stenosis, without spondylolisthesis is the commonest variety, degeneration can also cause spondylolisthesis, which is the next common variety. Then you can have pathological stenosis, which can happen in achondroplasia, where you have a short and narrow pedicles, thick pedicles, and in Cage's disease, where it can produce pathological. And other conditions like intradural tumors, okay, and spinal canal tumors, or extraosseous tumors, extradural, extraosseous tumors. These things can also cause lumbar canal stenosis, but these are very small in number. Very rarely it can be iatrogenic. When you do a surgery, decompressive surgery, where you cause more fibrosis, or there are some pathologies where it can go for ossifications. So those things after surgery can increase. So this can cause iatrogenic canal stenosis. And finally, post-traumatic, which is a rare one, also infections can also cause lumbar canal stenosis. But the commonest variety is the degenerative stenosis, where there is no listhesis or no other pathology, and gradually the canal narrows down, and we'll see that etiopathology also. Location, as I said, it can be a central canal stenosis, where the canal is compromised in the center, or it can be a lateral recess, or it can be a foraminal, or it can be an extraforaminal. Severity of the stenosis is usually based on the symptoms and the signs. So they can be mild, moderate, or severe. So symptoms usually patient reported, and signs we elicit. So it combined, we can say it can be a mild stenosis or a moderate stenosis and severe stenosis, and which can be correlated with radiological. So it's a complex thing when you put it in severity. So before going to the etiopathologists, we should always know there's something called a functional spinal unit. That means two vertebrae, the intervening discs, the facet joints, the posterior elements, the ligaments, and the muscles, which contribute to the functional spinal unit. So if you take spine is like a tripod. Okay, that means it has 3 legs. The main leg is the discovertebral joint, and the other 2 legs are the 2 facet joints which are in the back. So why it is important is, like any one which is getting affected can affect the others. So any degeneration or any problem happening in one of these legs and usually affect the other, and it stimulates a cascade which starts a degenerative process. So if you see this, the first one, earliest and first one to degenerate is the disc. So here you can see the normal disc right side, and you can see a degenerated disc on the left side. So as the disc starts getting degenerated, what happens? One leg is affected, so other two legs are getting the maximum burnt of it. Which are the other two legs? They are the facet joints. So what happens to the facet joint? This is a facet joint. You can see a nicely articulating facets there without any degeneration or any arthritis there. And as you see, this is an arthritic facet joint. You can see how it is hypertrophied, how it is degenerated. You can see a gas shadow in between the two facet joints, and also erosion of the facet joints on the other side. So the facet joint also starts degenerating. So when this cascade starts, what happens? So a disc degeneration, a facet degeneration leads to facetal hypertrophy. When there is a facetal hypertrophy and all these things, you have a ligamentum flavum in between these two lamina, which gets hypertrophy and it starts buckling. And it is also associated with the narrowing of the disc height. So all these things contribute towards the narrowing of the spinal canal. So it is not only happens in the central canal, it can happen in the lateral recess, it can happen in the foraminal region, and also in the extraforaminal region. So as it keeps on narrowing, it goes back. Then what happens? So if you don't address it in between, what is the natural history? What happens to it is like the canal stenosis happens, or it can go for a spondylolisthesis, or something called a degenerative scoliosis can happen. One of these three things can happen. And the commonest thing to happen is the canal stenosis, lumbar canal stenosis. The next is a spondylolisthesis. Rarely you can have a degenerative scoliosis. And finally, what happens? Osteophyte forms both in front and back and goes for an autofusion. So that is the final thing. So a disc degeneration usually leads to facet degeneration, then facetal hypertrophy, then ligamentum flavum hypertrophy, which causes the canal to stenose, the disc height reduces, the canal stenosis increases. Sometimes you can lead to spondylolisthesis, a degenerative scoliosis, and finally body tries to compensate for all these things by producing osteophytes and goes for an autofusion. But the last two things, the autofusion and osteophyte formation, doesn't end the problem there. So usually many of the symptoms happen before that. So what are the symptoms usually which happens? So when you have a disc degeneration, what are the symptoms it can cause? Usually it causes back pain. Many of the disc degeneration are asymptomatic, but there's mostly the symptomatic problem with the disc degeneration is the back pain. Also, there is a facet degeneration. So in a lumbar canal stenosis or a degenerative stenosis, more than the disc degeneration, the facet degeneration is more. When the facet degeneration is more, what are the problems they can have? They can have intense back pain, mechanical back pain. That means when they are loading the spine and when they're sitting for a long time, they can have these back pains, and then causes facetal hypertrophy. When the facet gets hypertrophied, the nerve roots are near the facets, especially the traversing nerve roots or the nerve roots which are supplying the legs. So they get compressed and causes leg pain. So facet degeneration causes back pain. There is a hypertrophy of the facets, which started compressing the nerve roots, it causes leg pain. Then you have the ligamentum flavum there in between, which also hypertrophies and buckles. And when it buckles, it causes compression over the central canal. And most of the nerves are there. And again, it causes the radicular pain. At the same time, there is a reduction in the disc height. As you can see here, there is a reduction in the disc height. So when there is a reduction in the disc height, you can see this nerve root. This nerve root also gets compressed. That is the exiting nerve root. So the proximal nerve root also can get compressed, and that also causes radicular symptoms. So these are the various things which happens, and over a period of time, if it goes for an autofusion, yes, the patient can get relief of all these symptoms, except for the radicular symptoms. The back pain can disappear, but he'll have a lot of restriction of movements. But autofusion is a rare phenomenon, not a very common phenomenon. So how do you diagnose lumbar canal stenosis? Lumbar canal stenosis is mostly a clinical diagnosis, followed by a radiological diagnosis. So how do you diagnose clinically? It is based on your symptoms and signs. So what are the things they can have? Usually these patients can have back pain, which can be mild to moderate. Unlike a disc degeneration, which is causing severe pain, in a lumbar canal stenosis, many a times the back pain is only mild to moderate. Especially sometimes when they have something called back catch, that means extension catch. The patient is able to bend, and then they are not able to extend. and they are held up in a flexed position of the trunk. This is called a back catch. So that causes very severe pain. So where there is a facetal arthritis and it causes severe back catch, and there is a loss of extension, there it causes severe pain. These people can also have gluteal pain because most of the muscles around the facet joint, okay, are supplied by the nerves called the sinovertebral nerves. And these muscles go and get all the way up to the sacroiliac joint. So they can also have gluteal pain. And when there is a compression of the root, they cause leg pain. And the most important symptom is the neurogenic claudication. So because of the narrowing of the canal and the compression of the nerve roots, these people develop something called a neurogenic claudication. What is it? That means when the patient starts walking, they start developing pain in the leg, which is proximal to distal from the upper to the lower, and is associated with tingling and numbness. And if the pain becomes so intense and severe, they have to rest or they have to change their posture. So usually it's called the when you go to a market or this thing, you have a trolley. So a trolley sign, they try to bend forward. What happens when they bend forward? When they bend forward, what happens? The ligamentum flavum, which is buckled and is compressing, okay, it gets stretched out. So the canal space increases and the patient will have relief of the leg pain. Or they have to squat, or they have to lie down on side. So these are the things which can cause relief of this, and this is the classical of a neurogenic claudication. When you talk about neurogenic claudication, especially people with smokers, they can also have vascular claudication. So that will be different. That will be from lower down to upper, that is from the distal to proximal, and usually relieved on standing alone. You need not bend forward or change the position, or just lifting a leg alone can be relieving the pain. And unlike neurogenic claudication, where the claudication distance keeps on changing, where every time when you start walking on taking rest, and vascular claudication, usually the claudication distance is the same. So every time they'll be able to repeat the same distance. So it's one of the most important symptoms which you can pick up is the new patient will come and say, I'm not able to walk for long distances. I'm not able to walk for stand for a long time. If I do it, I have a radiating pain which starts from my buttock and goes all the way to the legs down. And sometimes it is associated with tingling and numbness. And I had to take rest for my position or habitus to have a relief of the leg. So what are the neurological symptoms? The commonest one, they will have the tingling and they can have numbness or weakness along a particular nerve root. Usually, unless the canal stenosis is very severe, it usually affects a particular dermatome, particular root. So it will be dermatomal pain or a myotomal weakness, a particular nerve. Very rarely it affects as a combination. When the canal stenosis is very severe, or in sometimes when the canal is stenosed and you have an acute disc prolapse into it, you can develop something called a cauda equina syndrome. So what is a cauda equina syndrome? It is an areflexic bladder and bowel. Patient will come with acute retention or dribbling of urine, okay, and with a saddle anesthesia. So it is areflexic bladder bowel with saddle anesthesia with varying degrees of weakness in the legs. So that is one of the emergencies in spine surgery where you have to immediately take up the patient for a decompression. So it can be a very rare condition in a lumbar canal stenosis, unlike in acute disc prolapse, where in the lumbar canal stenosis you have a canal stenosis and then they are associated disc prolapse. These people can develop an intermittent cauda equina syndrome also in severe stenosis when suddenly there is an inflammation of the nerve roots inside on a acutely compressed cord and they will have urinary symptoms all over. So they may not have saddle anesthesia, but they will have urinary symptoms. They will have sudden retention of urine, or there's but they may not have saddle anesthesia and get this relief a bit dose of steroid and all those things. So that also is an important thing you have to see. Whenever you have urinary symptoms associated with leg pain, either with complete block of urine, or with the dribbling, or with intermittent block and release, you should suspect a lumbar canal stenosis on these patients. So that is a picture of a thing showing that myotomal pattern or dermatomal pattern where it usually spreads. So the next one is the radiological, is the X-ray. So X-ray, what do you do? What in lumbar canal stenosis are you going to see in X-ray? X-ray, you can see the facets which are hypertrophied. You can see the osteophytes. Sometimes you can also find out the reduction in the disc space in these patients. Also, sometimes you can see a spondylolisthesis on these patients. The gold standard is the MRI, okay, on these patients. In patients where you cannot do an X-ray, MRI, you can always do a myelogram, which is a CT myelogram. So apart from this, we have to also see some of the red flags in lumbar canal stenosis. These are not simple patients because not the patients with lumbar canal stenosis need MRI. So they need only an X-ray. So you can send off with an X-ray. But which are the patients? Even sometimes, this is a 70-year-old man who comes with a classical neurogenic claudication. Sometimes you don't even need an X-ray. He says, I have an X-ray which is 2 years back. Can you see and have a look at it? Because I cannot go for X-rays, flexion extension. I don't have time. And MRI, no, I cannot go and lie down on MRI. So, but there are some red flags where you have to see a history of cancer, either with previous history of cancer, unexplained weight loss, intravenous drug abuses, prolonged use of corticosteroids. This is not unusual in elderly people. People who are older age, that means especially above 60. Okay. And major trauma, patients had a major trauma previously. Osteoporosis, fever, or back pain at rest. Usually, the lumbar canal stenosis very rarely produces back pain at rest or at night. So these are red flags where you should evaluate. They can have features of canal stenosis, but they may not be a degenerative canal stenosis. It can be some other canal stenosis where you have to always evaluate and see. So X-ray, what are the X-rays we do? We do a standing X-ray. Yes, which is very important on lumbar canal stenosis. Many of the patients, they'll be able to stand. Very rarely, they won't be, patients will be lying on bed and coming. The next is flexion extension view. In a standing X-ray, if it is not showing listhesis, you have to do a flexion extension view. This is to make sure your decompression is not going to stabilize an already an unstable spine. On a flexion extension, if you see an unstable spine, you should be very careful before just doing a decompression. Then whole spine staining is needed only when there is a fixed deformity in a lumbar canal stenosis. Otherwise, it is not needed a whole spine staining. MRI is the gold standard, and people who cannot do MRI can do a CT malabar, dynamic MRI, flexor and extension MRIs. In cervical spine, it's very easy to do it, but in lumbar spine, it's very difficult. But standing MRIs are coming up now. We don't have any experience on dynamic MRI. But telling diagnosis as MRI is the gold standard, does it mean that all patients who have features of stenosis, means that they need treatment? So for that, we have to understand what are the various things we see on an MRI. Because in your practice, many of people with neurogenic claudication will come up with an MRI and show you, this is MRI. And the radiologists have reported that I have canal stenosis. So is it very severe? So that's the next question they will ask. And many times you will see the numbers there. The canal is narrow, 10.2, 7.3. So how to limit and tell the patient that how bad is your stenosis based on the MRI? Even though your symptoms are not bad, does it warrant anything more than this? For that, we have to further know something more about the classification of stenosis on MRI. Because X-ray, lumbar canal stenosis, you will see only the classical arthritis. But otherwise, MRI will show most of the things. And there the patient will come and see, even as a general physician, is it a bad MRI for me? Even though I'm not having symptoms, is it a bad MRI? Should I be cautious? Will I develop a paralysis? So these things can be understood and can be answered if we understand the various classifications. And we should know some classifications on the MRI, even though we don't treat them very aggressively. So there are various classifications are there. One of the commonest classifications we use is the Shiza's classification. So this is the picture you are going to see on the MRI, the canal. So there are how many things are there? There are 4 and so 7 classifications, 7 types. So to cut short, so grade A and grade B means it's only minor or moderate stenosis. So you don't have to worry. That means you have to see the nerve roots inside somehow. Whether you are seeing it to the upper end or whether you are seeing it to the lower end or whether you are seeing throughout the canal, doesn't matter. You see the nerve roots or rootlets inside. So that means that they are either minor or moderate stenosis. If you can't see the nerve roots, then they are severe stenosis. So in patients, most of these patients can be treated non-operatively. And these are the patients where you can see the nerve roots inside. You don't have to send them to a specialist. A spine surgeon or an orthopedic surgeon or a neurosurgeon. You can treat this non-operatively very safely on these patients, irrespective of whatever dimensions they have given. Many times you see only the dimensions, you don't see the picture inside. So the dimension doesn't matter. Actually, it doesn't matter whether it's 10 mm, 12 mm, 18 mm, 15 mm. No. As long as you can see the nerve roots inside, you can treat them non-operatively. And you need not scare the patient. If you can't see the nerve root inside, and if the patient is very symptomatic, please send them, to a specialist. If you can't see the nerve root inside, patient is not symptomatic, yes, you have to tell him to be cautious and look for symptoms and then caution them that you may have to visit a specialist if you develop all these symptoms. Otherwise, if you see the nerve roots inside, you don't have to worry about it. So, and this is another classification, same thing, where you can see that you can see the CSF all around, and first and picture you can see the nerve roots. Okay, other two pictures, you cannot see the nerve roots. So this is how you are going to see. So if you can see the nerve roots, you don't have to worry. 0 and 1. If you can't see the nerve roots like 2 and 3, you have to be a little careful in treating these patients. Majority of them will follow into the first two groups where you will see the nerve roots inside. These are a little bit more where the patients will have the nerve roots you can see inside, but they still have leg pain. So those patients, if they are not improving, then you have to see whether the lateral recesses stenosis or that they have a foraminal stenosis. So these are the next things which usually are seen by the specialist. As a general practitioner, we don't have to worry about it. We have to mainly worry about the central canal where the nerve roots are seen or not. So what is the clinical correlation? If you take this article, which is one of the earliest articles to say the clinical correlation on patients with lumbar spinal stenosis. So the severity of the stenosis significantly predicted disability. Okay, there is no doubt about it. The more the stenosis, yes, the more disability. But it doesn't mean that all patients have been seen. These are patients who are symptomatic. So patients who are symptomatic, in those patients who are symptomatic, the severity of the stenosis significantly predicted that disability. Yes, fine. But this did not include symptomatic patients. Okay, this is based on CT myelogram. The next thing is this is the clinical correlation of the central canal stenosis. Here you see C and D grade patients have a significant risk of failing conservative patients. So this is what you have to see. What is A and B? A and B means you are able to see the nerve roots inside on MRI. C and D means you are not able to nerve roots inside. So these patients, if you have a C and D, and if they are not responding to conservative management, don't keep on conserving them. You have to refer to a specialist. And A and B, even if they are not responding to conservative management, you can change your conservative management and try for some more. So that is the thing of interpreting the MRI findings and how you want to treat these patients. Foraminal stenosis, yes, it is there. So the clinical correlation on this thing also, what it says is like the MRI findings are now clinical relevant with association and reported disability. So cutting short. So this is the natural history. You see, yeah, this is a very good article. I should definitely discuss this one. These patients had dual stenosis, both in cervical spine and in the lumbar spine. But the lumbar spine was asymptomatic. They did surgery only in the cervical spine, these patients. And when they followed up these patients, they found even at 3 to 5 years, only less than 10% of the patient needed any surgical intervention. 76 to 89 patients, they didn't need any surgical intervention. That means it didn't progress. Okay, even though they had stenosis on the MRI. Okay, so many of these lumbar canal stenosis are asymptomatic and they don't have to be operated based on the MRI. It has to be purely based on their symptoms and signs. So to talk asymptomatic findings, MRI, asymptomatic patient, MRI findings, there is no correlation. Symptomatic patients, MRI findings, again, there is no correlation. Doesn't mean that more the symptoms, more the MRI stenosis. But in symptomatic patients, if the MRI findings are severe, then they don't respond to conservative management. It correlates with the rest of the treatment. So finally, what is the MRI is used for in conservative management? It is basically to say whether you will respond or not to the treatment. Okay, so that is the main thing. So coming to the non-operative management. So so far I've discussed about the natural history, the definition, natural history, clinical etiopathogenesis, clinical findings, and the radiological findings, and how to interpret an MRI. So coming to the non-operative management, 80 to 85% of the lumbar canal stenosis can be treated non-operatively. So only less than 15% needs an operative management. So what is this? So the importance of knowing the operative management, there are 3 types of management which has to be combined. Okay, so one therapy may not help. It is a combination of the therapy. One is psychotherapy, other one is the physiotherapy, the next one is the semi-invasive interventional therapy. So these are the 3 therapies which we have in non-operative management. So if you see the non-operative management, pharmacotherapy, you have NSAIDs. So NSAIDs are given only in acute back pain. These patients have acute back pain or they have acute radicular or buttock pain. You can try NSAIDs for some time. Don't for more than 5 days or maximum 10 days, and be careful. Most of these patients are elderly patients. They may be already having renal failure, or they may tilt the balance and end up with an ARF. So we have to be very careful in treating NSAIDs. It has to be under supervision. The next one is opioid analgesics. Non-addictive opioid analgesics can be tramadol, can be widely used for controlling acute pain. Very rarely they need morphine, unlike other symptoms. If they need morphine, you should be very careful. That means we are missing something else. So they need not be a simple lumbar canal stenosis which is causing pain relief. You can use selective serotonin and norepinephrine reuptake inhibitors on these patients, especially duloxetine can be helpful. These studies have shown that it is very helpful in treating lumbar canal stenosis. Tricyclic antidepressants, yes, they are also recommended, especially amitriptyline. But mind it, tricyclic antidepressants, even at a small dose of 10 milligrams, can cause severe dryness and walking instability on these, drowsiness on these patients, elderly patients, and the fall risk becomes high. So you have to calculate the fall risk. You have a calculation. I think most of you will know 1, 2, 3, and 4. So, and if 3 and 4 are there, it should be avoided. Okay. Or if you are using it on these patients, you should advise them to use an additional walking stick or a walker. Okay. And keep the lights on at night when they are using the toilet, because the chances of them falling down because of amitriptyline is very high. Then you have these alpha 2 delta ligands, which are not very helpful, like gabapentin and pregabalin. And these two things, they are not very good in lumbar canal stenosis. They are good in disc prolapses or in acute disc prolapse or in treating acute leg pain. But in lumbar canal stenosis, where there is no wrist pain and only claudication pain is there, not very helpful, but you can try it and see no harm in it. And again, you have to think about fall risk on these patients. Steroids have no big role unless you have a patient who have an inflammation which is causing infant cardiac, where you want to try with steroids for an acute relief of new urinary symptoms. Vitamins and trace elements are also used. That's very, I think that's one of the commonest use. But later we will see what is the efficacy of these. Coming to the various other non-operative managements, which includes physiotherapy, you have a stretch of investigation. Management is a huge in isometric exercises, stretching exercises, exercises. I think most of your people, like people who are living abroad, you will have a neck and back school. And most of these people have to get registered there, and they have to follow up the physiotherapy and other physical therapy, and they have to report to the doctor only after 6 months. So back school is a very good one. In our hospital also, we have a back school and a stress school for the people who are working here. So the first time I see the patient, I decide the patient has a lumbar canal stenosis, I send them to the back school, and unless there is an emergency, I don't call them back for 6 months. So it is managed by the physiotherapist, and every 3 months, there is a meeting where we together and discuss whether the patient is improving or not. And it really works in case of lumbar canal stenosis, that they have a direct communication with the doctor and also with the physiotherapist. Further, heat therapy, cold therapy, traction, massage, trigger point stimulation, and you have all these things are there. The last 3 things where I have included epidural steroid, root blocks, facet blocks, and sinovertebral nerve root ablations can also help in lumbar canal stenosis. Now we will see a little bit about the literature evidence on these things. So coming to the non-surg management, this is one of a landmark article which came up in 2006. They had 55 patients and they followed up cases of lumbar canal. So they used 2 therapy called the distraction manipulation and neural modulation. So these 2 things they have used, and this is the special spinal table which most of the physiotherapists will have, and they found that 75% actually improved, and only out of the 55 patients at 16 months, they only 2 needed follow-up. So this is a very good therapy, and in our center we recommend this for type A and type B of these SHIZAs. And definitely this article does not say what type of lumbar canal stenosis they treated, but we do it for A and B, and they show very good response. C and D, we try this if the patient is not very symptomatic, even though there is a severe stenosis on the MRI, we try this one. Okay, and if they are not improving, then we take them for surgery. And this is one of the main therapy we do, the distractive manipulation and neural modulation therapy, which you should try on your patients with lumbar canal stenosis. What about epidural steroid injections? Okay, even though it is very difficult to give epidural steroid, sometimes they can cause problems if it is not given correctly. It should not be given at the level of the stenosis because there's very narrow canal. Either you have to give it above level or below level, and it shows to reduce the pain and increase the walking distance, and they have documented this after an epidural steroid injection. I am not very favor of epidural steroid injection for lumbar canal stenosis. Rather than I try a root block on these patients. So this is a root block where you can see, you can identify the nerve root. Okay, and you can give a root block on these patients, and you can also find out how the nerve is compressed here, and you can have there's a classification for this also, and this also gives very good pain relief on patients. This is very helpful for patients on one side pain, and sometimes for back pain you can give a facet joint block. On the right side I show you a facet joint block which can be used. So these 2 things are very good armamentarium in the non-operative, a semi-invasive method. And finally, what is the recommendation of the US Association for the Study of Pain for Treating Lumbar Canal Stenosis? This is a very recent article, 2021 or 22, I think. So it says the recommendation one, yes, definitely lifestyle modification, exercise, manual therapy, and rehabilitation must. They give the best results. Plus or minus, you can give a trial of serotonin, serotonin norepinephrine reuptake inhibitors or tricyclic antidepressants. These are the medications they advise. They don't advise NSAIDs for a long-term use, especially paracetamols and vitamins or trace elements, opioids, even the pregabalins and gabapentins, and even so this is the recommendation of the latest recommendation for the US Association for the Study of Pain in treatment of non-operative treatment of lumbar canal stenosis. Thank you very much. I think I have covered the most of the aspects of the non-operative management. Thank you very much.
Thank you, Dr. Venkatesh, for the exhaustive and, as usual, wonderfully done lecture. So we are used to Venkatesh giving all these lectures, and there's nothing surprising for us to hear it again. So one quick question on this, Venkatesh. There have been a lot of articles saying that 60 to 70% of these patients don't require any kind of treatment at all, and they'll remain the same, if not get better. What is your comment on that?
Sir, we have very limited literature on asymptomatic lumbar canal stenosis. There is one Lance article back in 2002 where they found at 80 years, 38, 60 years, 38% of these people have lumbar canal stenosis, and at 85 years, almost 80% of them have lumbar canal stenosis. Okay, but they don't, and they say around less than 30% of these people are symptomatic. Okay, so that means 70% of them are asymptomatic. So obviously, when these patients, whatever the grade of stenosis, if they develop symptoms, they are likely to get up with non-operative management.
Okay. Thank you, Mr. Yeah. Now, there are some questions coming up in the chat box. One of them...
Can we take the questions after the second talk?
Yeah, that's fine. We'll do that then. That's
perfect. Either of the speakers as per the requirements of the medical.
Perfect. We'll do that then.
Sure.
So we'll now go on to the second lecture of today, which is to be delivered by another close friend of mine, Dr. Amol Rege. Dr. Rege, again, like Venkatesh, doesn't need any introduction into the Spinal Society and the Spinal Group. And he is the head of the Dinanath Mangeshkar Hospital Unit of Spine Surgery, extensively well-trained both in India and in UK for many, many years, very proficient in deformities, minimally invasive surgeries, and of late now, they say you can't teach an old dog new tricks, but then Amol is defying that by learning endoscopy and proven to be a master in that. Over to you, Amol.
Thanks, Karthik. So just share my screen. So is the screen visible to everyone? Yeah. So thanks, Karthik, and thanks, JPO and ASSI for giving me an opportunity to talk on lumbar canal stenosis. Dr. Venkatesh has covered excellently all the basics, and I'm going to talk on the surgical indications, give a flavor of various techniques, what are newer things, and how are the outcome of these techniques. As you know, most of our patients are very afraid of spine surgery. If you talk surgery to any patient having spine problem, they run away from our clinics. So to start with, I will just discuss one case. This is a 68-year-old female who has claudication. So these are the typical cases which we get in our spine clinics. The walking distance is limited to 10 feet. So claudication, as you understand, is that after walking a certain distance, they have to stop. And they have tingling numbness. And we always ask this ratio. I find this very useful in my practice, back pain to leg pain ratio. That gives you an idea is how much is the mechanical pain and how much is the nerve root compression pain. So her back pain to leg pain ratio is 30 to 70. Left side is more than right. It is very important. These are all elderly patients. So we always ask for all the comorbidities. Most of these patients will be eating a lot of pills, and you need to be aware about all the problems they are suffering because you need to treat the patient as a whole. So she's a well-controlled diabetic. Her neurological examination is very important in spine. So she has got weakness of her L5 dermatome. EDL EHL is grade 3 and hyposthesia in the L4 and L5 dermatomes. Now, whenever we see a patient, it's very important that we rule out vascular problems. So we always feel for the pulses, hip examination. All this is very important to treat the patient. And that's our MRI scan. As you can see that there is severe stenosis at these two levels. So this is all ligamentum flavum, which is hypertrophied, and the disc, your vertebrae has slipped. So it is almost the end of the cascade, which Dr. Venkatesh talked about. There is listhesis in this case. And these are the axial cuts. So this is the normal diameter of the spinal canal. And as you can see at L4-5 and at L3-4, the stenosis is very severe. You can't see the cauda equina so well. So it is very important that you see the films as treating physicians to know what exactly is happening and not just depend on the reports. We always take, as Dr. Venkatesh mentioned, flexion extension views. And again, you can see severe level, multi-level degeneration. And we take the standing flexion extension views to see if there is any instability. And you can see that there is listhesis in this case. So when such patient comes to us, they have usually tried all forms of non-operative treatment. And in Pune, it is very common for patients to try Ayurvedic treatment, homeopathic treatment, go to bone setters, because they will try and do their best to avoid surgery. So actually, we encourage patients to go out in the society, try all forms of non-operative treatment, and then only once they are really fed up of all the non-operative treatment and their symptoms is so severe that they are disabled, then only I talk to them about surgery. So surgical options for lumbar canal stenosis are a complete plethora of multiple techniques, from laminectomy to unilateral laminectomy, bilateral laminectomy, with instrumentation, without instrumentation, endoscopic techniques. And as a surgeon, it is very confusing for us to which technique to choose for one particular patient, which technique will give the best results in my hand. So in the next few slides, I'm going to take you through the various surgical techniques and what is the philosophy of deciding the technique. So as Karthik was asking about the natural history, this is one study about the natural history of the patients followed up for 49 months. So as Karthik was saying, it is unchanged in 70%. So they still remain symptomatic. In 15%, symptoms do improve and 15% they get worsened. So it is fair enough to try non-operative treatment for all patients. And as Dr. Venkatesh has told us the various non-operative treatment, if the patient has come to you without any non-operative treatment, you should encourage him for at least 3 months to try various forms of therapy, either caudal epidural blocks or physiotherapy, and see if that helps the patient. Also, you treat the underlying morbidities like diabetes, osteoporosis, etc. And only if they are not responding, you should offer them surgery. So there are trials which compare surgical versus non-surgical treatment, and those patients, it has been shown that surgery does benefit these patients. So you have to have an endpoint that if the non-operative treatment is not working, you need to offer them surgery. So which are the patients who are going to be indicated for surgery? Those who have neurogenic claudication, which is not responding to conservative treatment, or those who get progressive neurological deficit. As the patient I discussed, she's already able to walk more than 10 feet. She has tried everything. She's got a neurodeficit. That is an ideal. Her MRI shows severe stenosis. That is a patient which is ideal for surgery. But at the same time, before offering surgery, it is very important to remember that you should assess all the comorbidities with them. They have heart problems, they might have kidney problems, diabetes, and those who are very high risk, you may have to say no to surgery. Also, I would like to make a point that some of them may be having associated cervical stenosis and cervical myelopathy. So you should also see the upper limbs. You should also get screening of the whole spine MRI before you offer them surgery, because sometimes you might need to do surgery at both levels. As Dr. Venkatesh mentioned, you should do all the investigations and pull out the various differentials, especially vascular pathologies, peripheral neuropathies, hip osteoarthritis, neoplastic or any infective disorders. So usually you get EMG nerve conduction studies, arterial Doppler, a bone scan if you suspect any malignancy, X-ray of the hip joint, blood sugar, thyroid function test, treadmill test. So all this whole workup needs to be done before you offer them surgery, because these are elderly patients. Now, what is the aim of the surgery? Basically, aim of the surgery is to give them relief of their symptoms, to improve their mobility, to decrease their leg pain, and maybe improve their neurology if they have one. So, and at the same time, you have to preserve the biomechanical function of the lumbar spine. You should not add insult to make it unstable. So this is a photograph which shows that after a decompression, you want to see the cauda equina free from the compression of the ligamentum flavum and the bony stenosis. Now, which type of surgery to select? So I'll just describe in short what are the various surgeries which are available. So like this MRI shows severe stenosis. Now this can be treated by various surgeons in various ways. The classic gold standard is decompressive laminectomy. Laminectomy has a disadvantage that it destabilizes. So people started doing unilateral or bilateral laminotomies. That means you preserve the center and you do decompression in the local area. Then there was further refinement by using minimally invasive spine surgery, either with the tubes or endoscopic techniques. In certain cases, besides decompression, you also need fixation and fusion. And there is something called as interspinal spacers. So I will take you through all these techniques in very short. So the classical surgery is laminectomy. The advantages is that it is a very gold standard surgery. Surgeons are very familiar. It can be done at multiple levels. This surgery has been happening for years. Rather, whenever I go, I tell my anesthetist I'm doing a surgery, she always thinks it is laminectomy. Spine surgery is equal to laminectomy is the equation. So what you do basically is you take out the spinous process and you undercut the facets and the lamina, and you make space for the cauda and the nerve roots. So the disadvantage is that you remove all the posterior structures. So you might weaken the spine, and if you don't take care to protect the pars and the facets, you will destabilize the spine. So you have to take the care of protecting the pars and the facet joint so that you don't destabilize the spine. So it is the gold standard still for lumbar stenosis. Now, because there is a lot of muscle dissection, the technique has been modified, and what people nowadays do is also either do a base of the dissect the paraspinals on one side and then do a osteotomy of the base of the spinous process, or preserving both the paraspinal muscles, you can split the spinous process in between. So you preserve the attachment to the spinous process and the spinous process themselves. So that decreases the destabilization. So this is a modification of a laminectomy, which is nowadays commonly practiced. Then came other modifications to try and preserve the central structures. So one was bilateral laminotomy. So you preserve the central structures and you make openings on both sides and you decompress the cauda and the nerve root. This is the standard laminectomy. And then came another modification where you open on one side, you do a unilateral laminotomy and you decompress on the opposite side. So these are all modifications to try and preserve the stability of spine. So more aggressive technique, that is the laminectomy, if you don't take care properly, you can destabilize. And in that case, you might have to fuse. So this is the unilateral approach where you open on one side, you tilt the table and the microscope, and you decompress the opposite side, as you can see in this diagram. So these techniques are modifications of this standard laminectomy approach. Then came the tube. So basically, people started thinking that you should not damage the muscles. So you put in dilators sequentially, and then you put the 16 to 18 mm tubes, and then basically through the tubes you do the decompression. The underlying work is the same. The target work is the same. You decompress the cauda, you decompress the nerve roots. It's only the protection of the muscles and the ligaments that you're trying to achieve by these techniques. So basically, these are the dilators, as you can see, sequential dilators. You dock them and then you put this tube and then through the microscope you work. So minimal damage to the muscles happen. So this is how you do it. Basically, you use a burr and then you drill it. And then finally here you can see that you decompress the nerve roots and the chorda equina. Then came further modifications with more. Spine surgery has gone hand in hand with technology, and as technology changes, things change very rapidly, especially in spine surgery. So then came the endoscopes with knee arthroscope showing a big success. Endoscopy is also coming in a big way in spine surgery. So basically, instead of microscope, you have a magnification which is much more light quality, which is much more better. So endoscopic techniques came in, and this again has shown to be very effective. So basically, this technique is one I do, which is uniportal bilateral endoscopy. Unilateral biportal endoscopy. So you have two ports. One is the working port and one is the endoscope. So you put endoscope from one side, you put the instruments from the other side, and then you can decompress the spine, as you can see. So here you can see this is the ligamentum flavum, which you take off, and then you have this chorda in the root, which you can decompress. So the whole idea is to decompress the chorda equina, take off the hypertrophic facets, take off the ligamentum flavum, and free the roots. That is the whole idea of surgery. So here you can see the endoscopic view. After you free that, you can see the chorda equina. This is the central part, and these are the lateral recesses which have been freed. So this is the pre-op MRI showing the stenosis, a trefoil canal, and this is the post-op MRI, which you can see the drilling on one side, the lamina are taken from one side, and all the flavum has been taken off, and now the canal, which was so small, has been broadened up. So this technique has a lot of advantages: very two small incisions, less damage to soft tissue, faster recovery, decreased blood loss, decreased hospital stay, less infection rates, less complications. Now, when do you do fusion? So we saw decompression. These are all various techniques of decompression, from laminectomy, unilateral laminectomies, to tube laminectomies, to endoscopic decompression. Now, what is the role of fusion? If the patient's spine is stable, there is no role of fusion. Only if there is instability, that means, as Dr. Venkatesh said, in the end of the cascade of stenosis, you get either listhesis or you get degenerative scoliosis, then only you need fusion. So these are the two specific indications where we consider fusion, where we add instrumentation to stabilize the spine. Now the fusion is nowadays done by minimally invasive technique. So this is a degenerative listhesis. You can see it's a grade 1 listhesis. So you put in pedicular screws and you put in this cage, you reduce the listhesis, and basically all the instruments are passed under CM imaging by minimally invasive technique. These are the small cuts which we take, and you stabilize the spine and decompress. So if there's a degenerative listhesis, you may get away with just decompression, but it is better to stabilize, especially if there's a mobile listhesis. And if there's a degenerative scoliosis with, again, lumbar canal stenosis, in those cases also we do this minimally invasive technique of fusion. So here you can see this is all, the screws are passed by minimally invasive technique. So these are modern techniques which have developed with modern technology and cause less damage to the muscles and soft tissues. Interspinous process spacers came in a long way. Basically, as you know, classically, when patient gets symptoms of claudication, they stoop forward. So in flexion, the intervertebral foramen opens up. So there were instruments which were designed to put in the posterior part. Like here you can see this is the interspinous process spacer. So you jack up the spinous process and you recreate the flexion in the body and open the nerve roots. But unfortunately, all this has failed. So you have to be very careful as a surgeon what technology to choose. A lot of things come in fashion, fail and go away, but your patients might suffer. So unless it's been long standing and really proven and time tested, don't fall prey to newer techniques. So what decides the favorable outcome? As Dr. Venkatesh said, that if the severity of stenosis is very severe, the case we discuss is going to be a very favorable outcome. If the patient's symptoms are very severe, then they are more likely to benefit. And the willpower, the psychosocial factors, how post-op they are going to rehab also decides the outcome. So all these things are very important when you talk about surgery for stenosis. And finally, what is the evidence base for the treatment and outcome? As I discussed, that class 1 evidence to show benefit of surgery over conservative treatment exists. Always assess their comorbidity and cervical myelopathy. In severely symptomatic patients, conservative management is effective in 33% and decompressive surgery alone in 88%. So in severe symptomatic patients with severe stenosis on MRI, surgery is effective. Even in elderly patients, it has been shown in a lot of trials that surgery, they can benefit with surgery. So don't refuse to pay surgery to patients who are more than 75. If they are symptomatic, if their comorbidities are controlled, they deserve surgery. In patients with lumbar canal stenosis with degenerative scoliosis and listhesis, then only you instrument and fuse. Otherwise, just decompression is good enough. Thank you for a patient talk and thanks for the invitation. Thank you.
Thanks, Amol, for the lovely lecture. And, I'm sure most people will have an idea of when do you recommend surgery and what is to be done. I would, are there any questions from the chat box? I'll start with one question to Venkatesh. What is the role of pain clinics and local anesthesia in all these procedures? What is the role of pain clinics, Venkatesh?
Pain clinics are very good, very useful for back pain. And managing the claudication pain, it's like it has to be with local root blocks they can try. But it all depends on the amount of canal stenosis and as you said, as Dr. Amol said, that what the patient wants. Okay, so for a patient who is willing to undergo a non-operative management, it works very nicely. So because the non-operative management, unlike surgical, it takes a long time to respond and may not respond also. So people have to understand that before going to a pain clinic. This pain is not like an acute pain. So it's like a chronic pain which brought out on activity, not at rest. So the pathology is totally different. So back pain definitely helps. Leg pain, we have to be very cautious with pain clinics and local anesthesia.
Sure. Thank you, Venkatesh. Amol, there's a question for you from the audience. In achondroplastic lumbar canal stenosis, what will you do?
Yeah, so achondroplastic have a narrow lumbar canal and by birth, and they usually become symptomatic quite early in life, and it is multiple level. It's not usually 1 or 2 level. So if they are very symptomatic, they will need multi-level decompression. You don't necessarily have to fuse them because they may not be unstable. So you get their flexion extension, apilateral views on standing, and you may have to offer them multi-level decompression. And you need to take care of the pars and the facet joints when you do a decompression in those patients.
Sure. So Dr. Ankit has asked the question: How do you approach when secondary canal stenosis also has moderate disc bulge, disc level hypertrophy, especially in tubular decompression MISS?
Okay. Second, moderate.
How do you approach when secondary canal stenosis?
So basically, a disc bulge will be seen in most patients with lumbar canal stenosis, but that does not mean you have to do discectomy in all these patients. So main symptom you have to assess, and if it is claudication and it's mainly ligamentum flavum hypertrophy, you just need to remove the thickened ligament. You need to undercut the facet joints and decompress the root. You don't have to touch the disc in those cases just because you see on MRI disc bulges.
Yeah, if I may add to Amol, most of these patients do have what is called a pseudo disc, and that actually looks like a picture. So you don't have to address that. I think Dr. Bala has been wanting to ask or say something. Is he, Dr. Bala? Is he? I don't think I'm not able to see him across.
Sir, are you there, Dr. Balmukund?
Question answered.
Yeah, my question was about pain clinic, and it's partly answered, but this is one development. When we talk about sending patients to all sorts of specialists, homeopathy and Ayurveda and all that, I think they are better served in the pain clinic as well. There's no harm in trying various pathies, but combination of medical consultation, surgical, radiological, goes hand in hand with pain clinics. At least in UK, we have seen a lot of development of pain clinics, and it works quite well. Not only before operations, and then you can actually select patients who are not responding to pain treatment and are getting worse. They can go to surgical side. And after surgery also, pain clinics are useful because although success rate of surgery is very high, people are left with some pain or the other, which has been the main presenting symptom anyway. So in that case, they are served very well by the pain clinics after the operation as well. Some patients may even need more than one operation. In that case, in between time, they can be conservatively and relatively non-invasively managed well. I hope you could hear me properly. There's some disturbance in the line there.
Oh, we could hear you very clearly, Bala.
Yeah,
could hear you clearly.
I've seen from the anesthetist point of view, when I'm working with spinal surgeons in UK, and also having run a pain clinic, 2 pain clinics, in fact, in UK, I find them very useful. And in fact, we managed to avoid unnecessary surgery in a lot of patients, and also unnecessary investigations as well. So that probably is the future in as canal stenosis, both cervical as well as lumbar. Thank you very much for the opportunity.
I think what I would like to add on is not just the pain clinic factor alone. Now I think we're looking at multimodalities and multimodality clinics, where everybody is the group clinic which is there, where all groups of doctors are involved in a multimodality clinic, which is going to serve the patient. So that, in the sense, is now picking up slowly. Australia has been leading the way in this. I think we're going to see more of this in the future too.
I just wanted to ask Dr. Venkatesh regarding, as you beautifully talked about the conservative management techniques, and it would be really helpful for the young surgeons to decide whether to go ahead with the conservative management or the surgical option. I just wanted to know, Dr. Venkatesh, what is the role of steroids in acute cauda equina syndrome? Acute. Cauda equina is an emergency. We all know that, but few patients present little late. And the second part is, in your BMC study, role of manipulation or the traction in disc prolapse. See, many persons, they opt for, before coming to us, they opt for manipulation techniques. Just wanted to know about, is it really helpful, or traction? I personally think that I really fear with the traction and everything. That's why. Role of steroid in acute cauda equina. Second is the traction pick. Please. Thank you.
So we don't have any experience in giving steroids for cauda equina syndrome. There are studies which have shown that in cauda equina syndrome, it really helps. These patients have a canal stenosis and they develop urinary retention alone without saddle anesthesia. And there are no other urological problems. They don't have prostate hypertrophy and all those things. So these patients, there are studies, anecdotal studies, which say that steroids will help. I don't have any personal experience in the last 25 years of treating any patient with cauda equina syndrome with steroids. That's the first one. The second one is traction, manipulation is not advised in, the study says it is only for lumbar canal stenosis and not for disc prolapse. So it is very clear. The study was done only on patients with lumbar canal stenosis, don't have rest pain, and they have only neurogenic claudication. So here they have done that distractive manipulation with a special table. where they do it under neural modulation. Neural modulation, what they do is, if they have, for example, at 70-degree sciatic nerve stretch is positive on these patients, because many of these patients, they don't have a SLRT positive. So after that, they do something with the Lasix. Okay, instead of putting the leg down, in the same position, they do a Lasix and try to increase that. So that is the neural modulation technique. So in a Lasix, what we do is we just down till the pain comes down, and then we try to dorsiflex the ankle at the same position when the pain starts. After that, they try to dorsiflex so that they feel that nerve root gets stretched and gets accommodated for pain. Slowly try to improve the SLR. This is the neural modulation they do. So, and the distractive manipulation is purely a physiotherapeutic technique that they do it. It is no rotatory manipulation. It is only axial manipulation. That is in the one sagittal plane. It is not to be done in a rotational plane.
Right. And I regarding Dr. Anmol Regi, beautiful presentation. But importantly, you said that you should always screen the cervical spine in elderly with lumbar canal stenosis or any lumbar spine. That's an important thing for the young surgeons to take it. But you should always screen cervical spine in elderly.
Thank you, sir. I think that is very important because the lower limb examination can be masked by the stenosis, coexisting lumbar stenosis. So you may not get the classical upper motor neuron signs in lower limb. And you may just miss it. So it's very important that you ask the upper limb some symptoms like difficulty in buttoning, dropping of objects, tingling numbness, and also do a proper clinical examination of the upper limbs in all patients who present to you with lumbar stenosis.
Dr. Rishi Gupta is asking, for symptomatic acute and chronic degenerative disease, what is the role of selective nerve root blocks? Dr. Venkatesh, I think
actually the patient, most of them who have mild, moderate deficits, even with moderate deficits, like that means grade 4 and grade 3, we usually try these things and we wait for at least 4 weeks to make sure that even if it is not increasing, we try them conservatively, and the acute pain definitely goes off with these patients. So rather than trying a transforamen epidural steroid or an interlaminar epidural steroid, it's very difficult. If they have typical root symptoms and single root symptoms, they do very well with selective nerve blocks, even when they have moderate deficits.
Yeah. Now I think the question Q&A question round is over. I request Dr. Sushil Jain to please do vote of thanks and request the. Please go ahead.
Yeah, before going to that, I think Dr. Suresh wanted to ask some question. Dr. Suresh?
Hi, good morning or good evening. I'm Dr. Suresh Gupta. I'm here in USA. I'm a Amazonian, graduated in 1964, and I have been living in USA. Unfortunately, in the last few months, I was in India last month, developed symptoms of spinal stenosis with pain in my buttocks, hips, and lower extremity while walking. I sleep well, I have no pain. Only when I stand up, I have pain and walk. I have no comorbidities, and I have tried all kinds of conservative treatment, including acupuncture, epidural, gabapentin, non-steroidals, 2 courses of steroids, and everything that you can ask for. No response at all. I do walk, but I'm scared of walking. So I had seen a spinal surgeon who told me that at your age, he would not recommend surgery because of my age. He said, you are 80 years old, not 25. It will be high risk. So I'm asking both of you, the spine surgeon, as well as Dr. Venkatesh, to see if I'm missing out on something. I've had all kinds of tests, and everything is completely normal. And I'm in a dilemma as to what to do, what not to do.
I think that is what I'll do is I'll share the email ID of both the speakers with Dr. Suresh, and you can post the question directly, mail the questions, and if required, the investigation to them rather than discussing it here. It would be very
That's fine. Yeah. I requested them to send me their email address, and even I posted my phone number. I'd be happy to have a Zoom call or video call because, I need some help. I've seen doctors, all kinds of doctors here. I'm myself a physician, not that I don't like people here. I just thought I attend this conference and see what's happening.
Yeah, Dr. Gupta,
Dr.
I'm sure. Dr.
If
Gupta,
they
I'm
permit,
pretty
then
sure
I'll
that
share their email IDs
yes.
with Dr. Suresh, if you permit.
Yeah, but I have already shared my email with him and also the phone number to Dr. Gupta. He can check in his message. Dr. Gupta, I've shared it already with you.
Oh, great. Thank you, Dr. Venkat. Thank you.
I think there is a question from Dr. J.B. Bhala as well, if he's still.
That has been already answered. That has been already answered.
No.
Okay,
That was Dr. J.B. Bhala is my brother actually, and in India, and he has been a patient of spinal canal stenosis. So if he's still there, he might like to ask a question now. Unless he's gone.
He's there. He has to unmute his mic.
Yeah, Dr. J.B. Balla is online, but he has to unmute.